And now on to our elimination tests. So those tests that will aid us in culling down that differential list that we've created. So first, our lower quarter screen. Let's have a look at this. And here we go.
This is the lower quarter screen. Go ahead and bend down towards the floor to touch your toes. Any problems with that? I want you to try that again. Try to do more at your waist and back. Keep them on the belt. We're going to get on the upper mid back and the sacral area and try to give a bending moment for our overpressure with that one if active range of motion is painless and full. Now go ahead and cross your arms. Come on back. Any problems with that? So you don't have to arch the neck back like that. You just come straight back. Any problems there? So if you're wanting to give overpressure, and again, I don't always, we can get across the patient's forearm, purchase at the lower back to pivot over. Any problems there? Just be careful with applying too much pressure on that. Now go ahead and come down to the right side. Any problems there? No. And we're going to get on top of the shoulder here on the hip and try to bring those 2 points together for our overpressure. Same thing here. Any problems? And rotation. Let's slide back this way a little bit. Go ahead and rotate your body to the right. Keep coming all the way. So we block the pelvis. She's rotating to the right. I'm on the posterior PSIS on the right side. Wrap around to the anterior ASIS on the other side and give a little overpressure there. Now to your other side. Any problems with that? No. Now a little bit extra. Any problems there? Our combined motions next. We're going to go ahead and bring your right arm down to your left toes there. So if we want to give overpressure with this, we can come on the we can offset just a little bit from where we were with regular flexion. So come on the right side of the upper mid back and pelvic area here with the left hand on the left side and give our overpressure with our bending movement there. And the same thing in the other direction. And again, our overpressure if we're wanting to give that. And, go ahead and bring your right hand towards your back of your right knee. Any problems with that? Come back up. And if we want to give overpressure with that, again, which I don't always hear, it's a pretty extreme position. Go ahead and cross your arms across your chest again and go through that same motion. And as she goes through it now, we can give a little overpressure there. All right, our next motions here, we get you to go ahead and come on down and do a full squat for us here. We want to guard the patient appropriately and make sure that she's getting motion extension at the lower and thoracic spine, flexion at the hips, flexion at the knees, dorsiflexions all occur. Now, face towards me. We can also do a single leg squat. So go ahead and grab my forearms here. You're going to come down and try to do your single leg squat now. And come on up. Let's say this is for your more athletic patients when you're doing this. And then keep on the other side. We can also have the patient do a modified lunge. So go ahead and do a lunge for me. So look at the lunge itself. And again, look for hip extension on the side that's farther back. We're also seeing a hip flexion to a degree on the side that goes forward, our knee flexion, and gross forward through the sternum. That asymmetrical motion. If our patient's not able to do that, we can give them a nice sturdy surface to hold on to here. And you can hold on to that. And let's have you do that lunge. If the patient's not able to come all the way down, just keep that back knee straight. That's our modified lunge. Back up and repeat on the other side as well. So now let's have you come up onto your toes, take 10 steps in place without walking anywhere, again, guarding your patient very well. And now on your heels, same thing in place. Again, guarding your patient well. And that's the lower quarter screen.
All right. So our lower quarter screen there. And our neurologic testing as well. I believe we went over that last semester for the lower extremities as well. If we didn't, let me know and I'll make a video for that as well. And our special tests with good low negative likelihood ratios, they're going to be great for screening. So here, our lower quarter screen written out for you, as well as different neurologic testing that you'll want to do, and points of interest there for our neurologic testing. Here's a dermatomal map, but also important to consider that there are some variations when it comes to these. And a peripheral nerve map. And when we're doing our sensation testing, we want to consider, are we looking at a abnormality of dermatome or a peripheral nerve field? So we'll now go through some different tests that are commonly used for screening purposes. And we'll start off with our slump test here. We'll start off with our slump test here. We'll start off with our slump test here.
Okay, the slump test. So this is a test for radicular pain or radiculopathy.
And yes, I had to get pretty creative with this. It was very difficult for my wife and I to manage a time where we could both be free of work, or she could be free of work, and we could both have our toddlers under control.
Now for this test, we're going to have our patient sitting. We're going to say that our patient's right side is symptomatic. So the patient's right lower extremity, we're testing for radicular pain or radiculopathy. So we're going to have the patient.
Now, one thing I didn't say here that you'll see in the notes as well, but that I'm not doing because I'm with the skeleton right now, is you want to explain to your patient very clearly what to expect and make sure they know to tell you as soon as they feel any symptoms, more specifically any radicular symptoms that they've been feeling.
Place their arms behind their back together. Go ahead and slouch over for me. So patient would slouch. Now bring your chin towards your chest. We're going to flex the patient's neck. Now from here.
What you can't see, because I have a headless skeleton here, is when the patient brings the head to the chin of the chest, it's a good idea to just put your hand on the back of the patient's head. Now don't force them into more flexion or give any kind of overpressure, but we just keep the hand there so that when we're focused on looking at the lower extremity, we can feel if the patient extends the neck at all. It would be difficult to see both at the same time given the close proximity. So keeping that hand there just lets us feel for if their head comes back into our hand. But make sure you don't give overpressure with that.
We're going to extend the knee and then dorsiflex the foot. Now, if at any point during any of those motions the symptoms come on for the patient, we're going to stop the test and ask for desensitization. So let's say we get to the point the patient slouches, we flex the neck, we start to extend the knee, and the patient's symptoms come on here. Okay, we're going to stop. Now what I want you to do is to look up for me. So when the patient looks up, if the symptoms are alleviated, that would be a positive test. And then we'll ask the patient to look back down, and we're looking for resensitization again. That will further strengthen that positive test. So it doesn't matter where in this motion this occurs. If it starts to provoke as soon as we start to extend the knee, that's when we would do our sensitization and desensitization maneuver. If it starts when we start to dorsiflex the ankle, that's when we would do our sensitization and desensitization maneuvers. Now, that being said, sometimes it can be hard to get your legs under folks here. So we might need to come in front of the patient and grab the leg, extend here, and dorsiflex as such. So two different positions you could be in, either standing and lifting the patient's leg or sitting next to the patient as you go through this.
All right. So our slump test. And with this, research properties not looking as promising here. However, I can say with clinical experience, this seems to be a good test for screening. And essentially, if someone's lower extremity symptoms are provoked by a change in position of the head and neck, that is a good implication for something in that neurologic system, is that's going to be the only structure that really connects the lower extremity to the neck. So next, our straight leg raise test.
Okay, our straight leg raise test for radicular pain and radiculopathy. So we've got our patient in lying here. We're going to grab underneath the leg. And,
oh, guest appearance from my
In this
dog.
case, our patient's symptoms are right-sided, so on this side. Let me know if you start to feel your symptoms at any point through this motion. Now we want to keep the ankle at a neutral position there as we're doing this. As soon as the patient's symptoms come on, that's our positive test. So we're looking for reproduction of symptoms in the lower extremity with this, or reproduction of the patient's back pain. Now, this is also described with different sensitization maneuvers. So we'll come up, say here we get no symptoms, we might go to hip adduction as well. Or we might do hip adduction and internal rotation. This is also described with ankle dorsiflexion as a sensitization maneuver, or combined dorsiflexion, adduction, internal rotation. So there are different sensitization maneuvers as well, but to be clear, the straight leg raise test is as simple as lift the leg, look for reproduction of the patient's radicular symptoms. If they do come on, that's our positive test. If they don't, negative.
All right. And as you can see with this, we've got a nice low negative likelihood ratio, not so great with the positive likelihood ratio. So again, better for screening purposes than for confirming. And again, we can have different sensitizations, and one of the sensitization maneuvers that I left out is we can also use the neck flexion and then coming back to neutral, like we saw with the slump test there. So our extension rotation test, and this being a test for zygapophyseal joint pain. Come on, Zoom. All right, our extension rotation test.
Now for the extension rotation test. So we're looking for provocation of the
Notice the patient's sitting facing away.
Maybe thigh pain with this. This is for that facet arthropathy. So we're going to ask the patients to cross the arms across the chest. We're going to put our arm on top of their arm, and we're going to ask the patient to relax as much as possible. We're going to extend the patient over our hand. We're going to rotate in one direction, asking for patient symptoms, and then rotate in the opposite direction.
And I want to point out, because it's not terribly clear with the video here, that at any point if the patient's back pain is provoked, or buttock pain or thigh pain, we stop there. We don't have to continue on through the rest of the positioning here. So for example, if we were to extend the patient and the symptoms came on, that's where we would stop. We don't need to continue on with the rotation. Or if we just rotated a little bit, we don't need to continue on further if the patient's symptoms are provoked.
Asking for symptoms. Now, it might be tough for some of our smaller clinicians to be able to manage the patient like this. That being said, you can always stand as you do this as an option. And you might need to switch sides as you go through this. So we'll extend the patient,
rotate them towards us, extend the patient, rotate them towards us. So if possible, I like to be in sitting and go to both sides. If unable, I might stand up to try to get better support for the patient, maybe even get my body on them a little bit. All right. And again, our good negative likelihood ratio. So this is a very provocative test. So in other words, if I can take a patient all the way through this extended, rotated position, and it doesn't hurt them, generally speaking, I can be pretty confident that zygapophyseal joint pain is not the problem. However, the positive likelihood ratio is not good at all. So, in other words, this doesn't necessarily confirm zygapophyseal joint pain so much as getting in this position can hurt a lot of things. So if it was a disc issue, that could be problematic. And again, remember that our goal with screening tests is to rule things out. So we want a test that's really good at finding something if it's there. Therefore, if we get our negative test, it's probably not there. All right. And screening for lumbar stenosis, our clinical prediction rules here. So if there's 4 or 5 items present of these, so bilateral symptoms, leg pain is worse than back pain, pain with walking and standing, pain relieved with sitting, age greater than 48 years. If 4 or 5 of those are present, we've got a somewhat helpful confirmation there, but the utility in this lies better with having 0 items present. So if none of these items are present, we can be more confident that a patient doesn't have spinal stenosis. Now, that being said, note that this has a pretty poor quality of study, so that QUADS of 7. So not necessarily the most helpful tool, and a better study would aid in making this more clinically useful potentially, or at least give us a better understanding of whether or not this is a helpful clinical prediction rule. Now, our percussion test we went over in the thoracic spine unit. Again, note a decent positive and negative likelihood ratio, so really either way. But again, with this, we want to be somewhat cautious. If we have a high suspicion, say a patient with a sudden onset of low back pain after a mechanism that involves flexion and compression on the spine, patient takes corticosteroids and has for some time, or say the patient was osteoporotic, we might not necessarily want to do this test if we have a high enough suspicion and we're going to send the patient for medical referral anyway. That being said, let's have a look at that percussion test on the skeleton, if that's helpful. Okay, our percussion test. We went over this last semester, but we're going to have our patient in sitting, and we're going to percuss along the spine on both sides of the spinous processes here. Get a little flick in the wrist. We're looking for provocation of the patient's back pain with that. All right. So that takes us through our screening tests and on to structural stress testing next.